So we're all on GCS, right? We know how to evaluate. So the important thing here is this. One, I think concepts of being able to apply GCS that we forgot to say, like before leaving. Okay, so the questions can go like this. I gave you one where we describe the patient, right? Pretty straightforward. You stimulated pain and they didn't respond. You ask them a question, there's no verbal response, or whatever the case is, right? So you have to know, my point is you have to memorize or know the scale. Now, some of them are a bit different where it's just, they can just ask like about eye movement, and all you gotta know is the number for eye movement, right? Oh, they open their eyes spontaneously, what's the score? Or they'll describe the whole patient and all they ask is give the motor response score, or tell me the overall score. So it can vary, but at the basis of all that is the fact that you memorize or know the scale. Make sense? Okay. The other one is they'll give you a GCS score, and that within hours they now have a different GCS score. So what do you interpret, or what can you assume for that? What's your thoughts from that? Does that make sense? They might decline or have gotten better, right? So they started with a 9 and now they're a 14. Good. They're improving, or vice versa. 14, now they're a 9. They are declining. So it's the fact that you can observe that they're declining. You should be able to report that is what you really want. So those are important concepts, and then don't forget that 8 and under is total care, severe damage. Okay. All right. So good. All right. Let's do really fast. We're gonna do the electroencephalography. That starts on page 26. Okay, this is an EEG for short. We'll call it an EEG, electroencephalography. And just like an electrocardiogram, an ECG, it measures the electrical wave patterns of the brain instead of the heart. So, the important thing to know about the electroencephalography, the EEG, is one, non-invasive procedure that checks the electrical activity of the brain to determine abnormality. This can also show you information about brain function and highlight areas of abnormality. EEGs are most common, so look at the indication, because this is a question and people tend to get it wrong. EEGs are most commonly performed to identify and determine seizure activity. But they are also useful for detecting sleep disorders and behavioral changes. So one of the questions I've seen ask people miss it, like this, if I didn't know what the EEG was for. Oftentimes it's to see like what's triggering or causing seizures. Okay, also if there's any abnormal wave function. Or they also do them for sleep studies. Okay? Now the most relevant thing is how do we perform it, or more so how do you perform it and how do you prepare for it. So look at pre-procedure. Now most diagnostics we worry about post-procedure, but this is one of the few where it's a set. So pre-procedure, review medications and see if anything needs to be reported. Okay. Client education, I've seen these be the answer. Wash the hair to eliminate all oils, gels, and sprays. So the night before, morning of, or prior to the examination, wash their hair to clean up anything bad. If testing diagnostic for sleep condition, the client should sleep less prior to the procedure. To stimulate electrical activity during the test, you might be exposed to bright flashing lights or asked to hyperventilate 3 to 4 minutes. So, bright flashes or hyperventilate. I've seen that, so people didn't know that that's what they would be exposed to. Either flashing lights or they'll be asked to hyperventilate. And this will stimulate certain reactions within your brain. Avoid taking any stimulants or sedatives sedative medication as directed prior to the procedure, and avoid drinking caffeine the morning of the procedure. Meal fasting is not indicated, so no caffeine. And then what are like sedatives? Your opioids, benzo, stimulants, right? Things like, let's say amphetamines for the category. No cocaine, meth, methylphenidate, like ADHD medication, right? All you cool college kids who are doing math, you're like, no, I'm not. I just use Adderall to study. In case you didn't know what Adderall is, it is a legal form and a slightly different composition of meth. So admit to yourself when you look in the mirror and you take an Adderall that you are. You are certified method is prescribed. Diagnosed. Doctor said you're a method. I'm just kidding. Jokes aside though, methylphenidate is just a slightly different composition of meth. Yes. Of course.
It's extremely addictive.
It's, yeah, so jokes aside about like calling yourself a method, but methylphenidate, which you should have learned in term 3, right, helps you increase focus, treatment for ADD or ADHD. Jokes aside, the composition is very similar to that of, again, like recreational drugs like meth. It's just slightly different, and of course, it's dosage and adjusted and completely synthetic, so, right? But it sucks when it's prescribed to kids, and there's like a whole debate now on about it for so many years because of the fact that as they've aged, even now into their 20s and 30s, they're already suffering severe, like, not just addiction, but more than anything, organ problems because of the fact that they've had to be metabolizing this compound. Yeah. So, anyway, yes? We understand pre-procedure? Okay. So, it's not all awful. The real debate is, right, how long or how often or how this. Because obviously some people need it. It's just like seizure medication. Seizure medications are even worse at some point. They're very, very toxic. So what would you prefer? That? Or the fact that you're like seizing all the time or to die from a seizure? So doctors prescribe these and seizure medications like as a last resort usually. Like they try not to. Okay, intra-procedure. So what's gonna happen during the procedure? So what you teach before. Now intra-procedure, top of page 27. The procedure generally takes 45 to 120 minutes. So right, like 45 to 2 hours. There are no risks associated with this procedure. With the client resting in a chair or lying in a bed, small electrodes are placed on the scalp and connected to a brainwave machine and computer. The electric signals are recorded by the computer. Notations are made when the stimuli is presented or when sleep occurs. Post-procedure, resume back to normal activity. Very straightforward. There's no risk. Yeah. They're just measuring the brainwave pattern.
It's like looking at the heart rate.
Yeah, but they sometimes can want to elicit the seizure. I shouldn't say no risk. I hear what you're saying, but in short, I don't think they'll sign you with 1%. And in some cases, they want to trigger the seizure, and then they can see what's happening. Yeah. No, they don't have to shave it, but I mean, it helps. I've seen them do it with, but I've seen them do it with hair, it's fine. They might just try to get in there, like if it's really like out there, you know, you might just go under.
They like spread it.
They try to place it more, yeah. But usually it's just like a whole little thing, they just like. Okay, are we good on EEGs? All right. Let's go over CT scans, which is still there on page 26. Left side, cerebral computed tomography scan, which is a cerebral CT computed tomography. Okay.
The cerebral computed tomography.
All right. So CT scans. Now the important things about this is that with CT scans, what can be used? Contrast media or dye. So look at consideration. So we know that CT, right, is similar to an X-ray. Use a little bit of radiation. We'll get imaging, cross-sectional. Okay. Now this, if the client is pregnant, a determination should be made about risk versus benefit. Generally, they don't like to because, again, radiation exposure. Pre-procedure, nursing actions. If contrast media and or sedation is expected, instruct the client to refrain from consuming food or fluids 3 to 4 hours prior. So they're going to use contrast media, what you know as dye. Right? 3 to 4 hours NPO. Hours. NPO. Check for allergies too.
Selfish or iodine.
Shellfish and iodine. And then what labs do we test? Immunoavid creatinine, because they need to excrete it through the kidneys, so you check kidney function. Now, because this procedure is performed in supine, place the pillows in the small of the bags can help assist them. Inform the client that various clicking sounds will be heard, and ensure that the client is not wearing any metal prior to the procedure. So even though it's not because of a magnet, but just for imaging, no metal, so it doesn't interfere with the imaging. Clips, dentures, hairpins, jewelry, make sure you remove all that. The list is there in your book. Okay? And intra-procedure, they remain there with their head stabilized, they have to remain still. Post-procedure, there is no follow-up care associated with CT scan. If the contrast media is injected, monitor for the allergic reaction or changes in kidney function. If they were sedated, remain with them until stable. Now, this is where, you see, we go over this info. Now, let me bring an emphasis to how we want to study for these when we read over it. Because I do hear you where some people are like, hey, we're going over the book. It's like, yes, because that's where it contains the answers. But remember, application. So let's see how they could twist this up, for example. We also left out one thing right here. What should they stop? Metformin. It's a medication for diabetes, if you recall. Usually 1 to 2 days before and after. Now, you see, we write this down, but remember, you're trying to think ahead with application. This is where people lose track of it. So usually a question can go along the lines of, a patient is getting ready to go for a CT scan. Yes? Yes. Okay, they're gonna go for a CT scan, 64-year-old female, right? Is gonna go for a CT scan for a cerebral angiogram, or right, like for like cerebral edema or whatever the case is. They're gonna inject contrast media, and they'll say, go ahead and be like, what would be a contraindication to this procedure? Now it could be straightforward, the shellfish allergy, or they'll put out those are two of your answers. They say A, B, and they'll put like a peanut butter allergy, and she takes, I don't know, Detamir insulin for her diabetes. She reported. No oral anti-diabetic, she takes Detamir. So those are your answers, right? Or you see these things. So, or we can erase one of this, but hemoglobin 9, right? So in this case, you can remember these things. Now the answer is B, which would be the creatinine. But the problem is that then people get thrown off by the level. Does that make sense? Because then they're like that. Or in this case, you're like, well, we just talked about you gotta report BUN and creatinine. So let's change this. Let's say the creatinine was that, and C is now, they also take metformin and hemoglobin of 9, Detamir insulin. So then, why? Well, why is it not my creatinine? Because it's within range. It's within range. That's why people are like, oh, the answers are correct. No, they're not. The creatinine is within range, which indicates good kidney function. So it's not a reason to stop the exam. Does that make sense? I could give you versions of this for days. The other one is they took metformin 3 days ago, and again they give you the creatinine of like 2.1. And then people are like metformin, and they're metformin, because they just see metformin. Make sense? But it's past the time, they haven't taken it in 3 days. So then the indicator for the function is creatinine. Right? We could throw BUN in there. Oh, they have a BUN of 15. So is it the creatinine, the metformin, or the BUN now? So the creatinine is out of range. The BUN is within range. Yes.
My question more was when you first wrote it with the BUN 27 and the creatinine 1.9.
Well, then it's not going to be a situation.
Okay, that's like a you mistake or
generally, in real life, creatinine and BUN fall hand in hand. When one is out of range, usually so is the other. So that's why it's usually not seen on test in that way, because they'll just give you one or the other to indicate kidney function. But this is my point. Yes? Now, other diseases, for example, when we go over ICP, I see people get caught up with, I tell you, or for example, we'll say like, if people, like what's a risk factor for, I don't know, what the hell did we just cover recently, right? Like, for contraception. And we're saying people who have cardiovascular diseases. So they'll tell you who's not at risk for it. And I've told you like hypertension, DVT, history of MIs. So then they don't tell you that. Instead, they'll tell you that her regular blood pressure is 157/90, right? And so then, and that's one of the answers. And then she hasn't smoked in like 20 years, but she used to as a teenager. And then, right, like they give you all these answers. So people, because you're writing down in your note, hypertension. You look for hypertension. But this is hypertension. She has a consistent reading. It's just giving you the value now. Does that make sense? So I tell people, you have to be able to apply what we're doing on here. I tell you this so it doesn't throw you off guard. Whenever I tell you, check BUN and creatinine, if you don't know the levels of BUN and creatinine, that information is almost lost on you. Because of the fact that if I gave you a correct level, you're still gonna pick BUN and creatinine?
Yeah.
No, it's a correct level, it's within range, just indicates
Normal function.
normal function, the kidney is fine. So that's what I want you guys to focus on whenever we're reviewing the book. Yes, I'm covering concepts for you. Yes, I'm telling you the risk factors, but those risk factors need to be able to be translated to you. Make sure you check for respiratory rate. So how do you know for opioids what's too low? Below 12. So I see people miss that answer when I put respiratory rate of 14. They're like, well, we're supposed to check for respiratory depression. I said, that's not respiratory depression. That's normal. Make sense? So it needs to transfer to you like that. No patient, I tell that people when they're like, well, do something if they're hypotensive. It's that when you take their blood pressure, I always give the example, the machine doesn't tell you hypotension. It'll give you the number. It's gonna give you their blood pressure. And you need to know if it's
Hypo or hypertension.
hypo or hyper, or what does it mean to you?
Interpret.
Does that make sense? So you are there to interpret the information. You're there and you're gonna review the lab. Same thing with diuretics. That's why people form is such a killer, right? They're taking spironolactone, they're taking a loop diuretic. You know to check the potassium, but if you don't know the potassium level, there's no point, because then it's lost upon you. So remembering, like, this is why nursing and the medical field is so complex, at least for licensed personnel, LVN, RN, doctors, PAs, because you're not only in charge at this point of memorizing or knowing the information, but of being able to act upon it, apply it. You have to make a judgment at times that doesn't seem to be by the book, but it should be safe. Does that make sense? So, hopefully, as we're going through this, I know it can seem boring, and remember, when we're reading this from the book, it should translate to an application. That's why I give you examples or scenarios of question, so that you're hopefully trying to apply the information. Does that make sense? And that just comes with practice. So if people tell me, well, should I do practice questions, or should I read the book? It's like both. You should read the book to gather the information, and you do the practice questions to practice applying it. You're never gonna see those questions on the exam, because they're practice questions. But they at least saw if you were able to apply it or not. So when I tell people, when you read questions, when you do practice questions on ATI, on your book, or wherever, you should not just like try to figure out or guess the right answer. You should have a reasoning, as simple as it is, of why that's your answer. We call that the rationale. Right? I doubt you would ever go to a patient and just be like, lower the head of the bed. Why? Right? Why would I do that? You don't just go and you're like, we should just lower it. Just lower it. Just because. Yeah, he's having trouble breathing? High power him. Raise him up, raise him up. Why? Why are you raising it up? Like, does that make sense? You should know why. If you don't know the why, even to the correct answer, it's difficult. Are we good? Yes.
On your test, are you gonna put ranges of the labs, or which labs are you going based off of? Because Sarian has different ranges,
Okay.
so what do you use?
What's creatinine?
Yeah, like what is it to you?
Oh, okay. Carla's not here today. I'm gonna see if she can get me the updated version of your book, because I see that your book has also changed, which means your comprehensive that you'll receive at the end will change. Usually they provide a sheet, so I will provide you a sheet for the ranges that I will go based off of. And now you said that, then we'll do that.
Okay.
So will they be on the test, like that sheet or anything to help you? No.
Okay.
But we will have it, so we
Yeah.
can memorize.
So you can memorize it now.
Yeah.
Oftentimes, now, even though you get your new gen or engine quick, whatever the hell they're called, they give you the range usually. They give you ranges.
Yeah, yeah.
So that's a good, because in real life, that's true. Like,
They do give you.
they give you the range. The computer will always give you the range. And then all you have to do is interpret it. Does that make sense? So, it's fine. So it's, again, we're shifting, and the medical field has shifted from, we don't need you to memorize, I need you to understand. The information will be there, you know? A lot of people bag on that. I've seen pictures of like, where they're like, dude, when your doctor's like WebMD, how to wrap an ankle, I saw one the other day. And it's like, that dude probably hasn't wrapped an ankle in like 15
Yeah.
years since he was in med school. Like, of course he doesn't know how to. You get what I mean? So unless you're working in ER where you're currently dealing with sprains and stuff like that, you probably did forget how to spiralate an ankle. And that's fine. He's looking how. I'd be shocked if like, I hope I do it right. Like, screw that, you should review. Like, it doesn't go beyond you to know how to do it. I'll tell you, I'll be the first to tell you. Sometimes you guys ask me something and I'll tell you, I don't know. I don't remember. But if I go in your book and I read it, I will quickly either recall because I've seen it before, or I can quickly interpret it that it'll sink in. It comes back. But it's not perfect like that. But is the understanding there is what you want. Okay? If you do that, you'll pass this class, no problem. And I especially heard to a few people, we're past the easy part for here at Term 4. Management and repro are easy. Okay, there's not a lot to go on it, and arguably the only thing you should really like that's really like relevant to like moving forward that's not just knowledge based is the turf. I guarantee you they're gonna ask you about turf on your management project. Okay, guaranteed. Something about BPH or turf. It always happens, but I don't know what. Med-Surg.
Oh, Med-Surg.
Oh yeah, Med-Surg.
Everything else.
So, I don't know what they're gonna ask you, but, yes.
So